All right. I think we are rounding the corner on the magic 12:03, and Kimberly has started us with recording. So thank you all for joining us for Department of Medicine Grand Rounds today. We are super excited about our program today, and we have three very talented and highly qualified speakers to talk to us about COVID updates for this season. So really high yield information. And as always, I invite you all to text me and put your questions in the chat so that we can make use of our time at the end to cover as many of your questions as possible. Um, Caitlin, do you want to go ahead and share your slides while I do our introductions? Um, I'm going to pull up my thing. That looks great. Thank you. Okay. And so we have three fabulous speakers who will be giving us our COVID update today, where we'll be talking about vaccine technology for COVID, and then also treatment of COVID. Dr. Caitlin Jetelina will start. She is an epidemiologist, scientific communicator, and social entrepreneur. She is the founder of Health Trust Initiative, adjunct professor at Yale School of Public Health, and a senior scientific advisor to several government and nonprofit agencies, including the CDC. Sorry. In addition, Dr. Jetelina is the publisher of Your Local Epidemiologist, a public health newsletter that translates ever-evolving science to the public, reaching over 400 million views in over 133 countries. Dr. Jetelina was recently named a Time 100 Most Influential People in Health. She resides with her husband and two toddlers in San Diego, California. Thank you so much for joining us today. Our second speaker will be one of our very own, Dan Gracia, an assistant professor in the Division of Infectious Diseases with a secondary appointment in the Division of Preventive Medicine. He completed his MD residency fellowship and two master's degrees with us here at Emory, and his research activities are at the Hope Clinic of the Emory Vaccine Center, focused on clinical and translational research on vaccines, including vaccines for COVID, influenza, and tuberculosis. And then finally, our third speaker today will be Kara Chu. She's an associate professor of medicine in the Division of Infectious Diseases and the Center for Clinical AIDS Research and Education at UCLA. She's an infectious diseases clinician and clinical translational investigator whose research focuses on clinical trials of therapeutics for COVID-19 and HIV. She directs the UCLA CDU Center for AIDS Research Clinical Science Core and leads the UCLA Care Center Clinical Research Site for NIH Division of AIDS, HIV Network Treatment and Prevention Trials. It's a mouthful. She earned her BA and MD through the program in liberal medical education at Brown University. And fun fact, she and I are fellow alumni and buddies from the same med school class. She also completed clinical training in internal medicine at UCLA or UCSF and clinical and research training in infectious diseases at UCLA, where she also earned her Master's of Science in Clinical Research. And so we are extremely fortunate to have all three of these wonderful people here to talk to us today about COVID updates. I'm going to hand the mic over to Dr. Jetelina, and then I think after you're finished, Caitlin, if you want to just hand it over to Dan and he can share his slides, and then we'll go to Kara after that. All right. Thank you so much. And I will hand the mic to you.
Awesome. Thanks for having me. I can tell that none of us are busy whatsoever with those introductions, but I'm really excited to be here. I'm Caitlin Jetelina. I'm an epidemiologist. One of the silver linings of a pandemic is we no longer have to explain what an epidemiologist is, that we are not skin doctors, but we are disease detectives, right? And it's our main job is to find patterns. And because if we can find patterns, that means things aren't random, but they're predictable. And if they're predictable, that means they're preventable. So I'm going to run through a couple patterns for you guys around COVID-19. And first, I want to look back, take you on a journey, looking at some of these patterns that have been emerging to help you think through really what we're expecting this fall and winter and even beyond. So the first pattern is transmission dynamics or seasonality. This is wastewater over time, and we really see a remarkable stability in our winter peaks. In fact, since 2020, our winter peak has happened the same week year after year. And this is pretty typical for respiratory viruses like flu and RSV, right? But this is actually pretty incredible to me, the stability, even through 2020, given it was very novel and still really finding its bearings. Unique to COVID-19, and I'll go into why, is we also have summer peaks happening. And these are also pretty consistent, right? These peaks have been happening between August or July and August the past 5 summers. Interestingly as well, you'll note that some of these summer peaks are really consistently lower than the winter peaks. But that's on a national scale, that these summer peaks are lower than the winter peaks. A very interesting phenomenon to at least us geeky epidemiologists is when we start looking at the height of these peaks by region. So, for example, this is wastewater in Hawaii the past few years, and you'll see that here and in some places in the South, the peaks in summer are actually higher than their winter peaks. And this really follows very closely to the Southern Hemisphere patterns we're seeing in like Australia and New Zealand, for example. This is compared to, for example, northeastern states like New York, which seasonality, which we typically think of, right, peaking in winter, is peaking in winter and is higher in winter than summers. Now, there are these transmission dynamics. So, having a winter peak in the same week every year is due to the combination of three main factors. One is that COVID keeps mutating and it keeps mutating quickly, about twice as fast as the flu. So, when we'll have twice as many peaks as the flu. So, right, we have two peaks for COVID instead of one like for flu. But this is what viruses do, right? They mutate to survive. And the way COVID is surviving is to mutate to escape our first line of defense, which is our neutralizing antibodies, causing these cyclical infection waves. The second driving factor of these dynamics is waning immunity. So each wave, we have about 20 to 30% of the US population is infected with COVID-19. So more so in the winter, like we just saw, which means that this virus has plenty of pathways to find due to low immunity in the 70 to 80% of the rest of the population. Also, our vaccines are great, but they are not perfect. And there is this waning protection after infection or after vaccination in the first few months that is also contributing to these dynamics. The third factor is behavior change, right? So people move inside during the heat in the South. And so we start seeing more spread because COVID-19 spreads fantastic indoors. During the winter, people move indoor toward the cold. And so we also see this contributing to spread. Also in the winter, we have holidays, we have school starting, which is really opening up these new social networks for more opportunities for the virus to spread. Overall, though, at this point, the majority of epidemiologists really think that we have entered the endemic state of COVID-19. COVID is here to stay, and there's relative predictability without having this full-blown emergency. Now, we all know in this room is that endemic doesn't necessarily mean there's no suffering, right? TB and malaria are endemic, but causes millions of deaths per year throughout the globe. And I'll show you that COVID is also continuing to show its teeth, particularly with the most vulnerable. But another way to look at endemic is, I like this graph from the WHO flu team, actually, that came out a decade ago, I think, that there are different phases of a pandemic, and we are out of this alert phase and even out of this transition phase, and now more in this inter-pandemic phase of preparedness. And we have to be hyper focused on preparedness for the next pandemic, because we certainly learned a lot as we went. The good news is, even though we're getting these consistent transmission dynamics, severe disease has attenuated with COVID-19 over time because of immunity, right? So I plotted hospitalizations over time, and before COVID, we had about, 500 to 700,000 hospitalizations in the United States per respiratory season, most from flu, but also from RSV. In 2017, I pointed this out. We had a really bad flu year, which got up to about 800,000 hospitalizations in the United States. But then, of course, the pandemic hit, and hospitals were strained, right? Because we have all of a sudden this new threat in our repertoire, adding to the cumulative stress on our systems. And we can see how this has really changed over time. So in 2020, 2021, very low rates of flu and RSV because of non-pharmaceutical mitigation measures. But still, we had close to like 1.3 million hospitalizations that year just from COVID-19. Then we go into this Omicron tsunami, still low levels of respiratory viruses, but like the wind, we could just do very little to stop this, had over 1.5 million hospitalizations. The past 2 years, it's been clear that the gang has been back. Last year, we saw about 1 million hospitalizations. The biggest question here is, will this continue to decline, or is this just our new normal to see about 1 million hospitalizations per year? Obviously, we don't know. We do think we're going to hit a threshold of decline. But as you can tell, there's just still a lot of stress on our hospital systems, even more so than the worst flu year we had in pre-pandemic times. Now, if we look at who's getting hospitalized by age, it's those over 65, right? Those have consistently been at the top of the list. And I don't think that really surprises anyone on this call either. One thing that usually does surprise people, though, is that the second most hospitalized group is actually babies under 6 months old for COVID-19. Of course, they're not eligible for the vaccine. So this really highlights the need and importance of vaccination during pregnancy, something that hasn't really been part of the American narrative over the past couple of years. Now, if we look at these kiddos by medical condition, this is 2022 data. This is the last data we have. We see that the vast majority of kids under 5 have no underlying condition. So these are healthy kids that get very sick from COVID-19 kind of at random. As kids get older, there still is about 20 to 30% without an underlying condition, which is that red bar. But the sicker kids are starting to get hospitalized more. So those with asthma, those with neurological conditions, and also feeding tube dependence is the third leading cause of hospitalization among kiddos. Oops, my pretty circles. Okay, now for adults, there's still about 20% of adults hospitalized without underlying conditions. But when we start looking at the conditions, though, in adjusted models, every condition listed here, there's 8, except obesity, are found to increase the risk of COVID-19 associated hospitalization. This magnitude of risk is varied by condition as well as age group, right? So in these models, age over 75 remains a strong risk factor for hospitalization, even after these adjusted models, including the conditions, medical conditions. And like I said earlier, endemic doesn't necessarily mean no suffering, and it doesn't mean no deaths. This past winter wave at its peak, we had about 1,300 Americans die from COVID-19 per week. But if we look at the past respiratory season, COVID-19 continues to outrank flu. But this has dramatically declined over time, just like hospitalizations, right? In 2022, COVID was the 4th leading cause of death. 2023, it's now the 10th. This year, provisional data is putting us COVID at around the 14th leading cause of death. So it continues to decline. And then there's morbidity from COVID, right? It's incredibly challenging to understand who has had long COVID, how many people get it for a number of reasons. But we epidemiologists do think prevalence is decreasing over the time because of immunity, because of vaccinations. Somewhere between 3 to 5% prevalence of long COVID is happening today. Will it continue to decrease because of immunity? Time will tell. We're not entirely sure. Something else that we've been paying attention to is vaccine coverage over time, right? Flu coverage has remained relatively stable the past 10 years. Around 40% of Americans get the flu vaccine every year. And this actually continued throughout the pandemic in fall of 2020 and 2021. The first primary series, we actually had incredible coverage. I don't know the last time 90% of Americans agreed on one thing. But since we've seen a nosedive of these annual vaccines for COVID-19, creating really an interesting paradox that coverage is much smaller for COVID than for flu or even for RSV. What keeps me up at night, though, is these older adults coverage, that these are the highest risk over 65, and they're not having really high coverage for vaccines either. And so I think that's one of the main reasons Health and Human Services is having this massive campaign to target older Americans to get their vaccine this fall. So that brings us to today. And in today, we're coming off the heels of this big summer wave. In fact, the national wastewater got close to the winter peak, which really hasn't happened before. And this is all consistent in all four regions. I highlighted the South for you guys. And it's just like middle of the road, right? So basically right now, enjoy the reprieve because we expect this to start increasing in November again. Going into fall, and I think another speaker will talk about this, I think it's prudent to recognize that there's a lot of vaccines for the public to keep track of. Who is eligible? What are the options? What's going to work? What should I get? When should I get it? And all of these things vary. So I created this one pager for my newsletter for people to print out so patients actually have a little more clarity and can help keep track of these things. And this year is even more complicated, right? Because not everyone needs an RSV vaccine because it's not annual. So really trying to anticipate concerns and fill information voids proactively. And that leads us to the future. So going into the future, into this fall season, I have three really big questions that we're paying attention to as epidemiologists. One is the height of this COVID-19 winter wave. CDC forecasts we should expect the same amount of COVID hospitalizations about last year. So I think that was about like 1 million total. I think we're actually going to have maybe the first mild COVID-19 season, given the massive summer wave of immunity. Again, time will tell about this. Second big question is vaccine coverage, mostly because we have this pull and push, right? We have this huge campaign. I think they're putting $100 million in this campaign. But at the same time, a lot of people just got infected. They don't need a vaccine right now. People are tired. Access is getting harder. And so it'll be interesting to see how all these factors really play against each other. Here is the vaccine coverage today for COVID-19. It's about 6%, 21% intend to get vaccinated, which is a little lower than we saw last year. Same with flu is going to be lower than we saw last year. Thankfully, there's a lot more interest in RSV this year. And then the third thing is timing of peaks. One thing we have going for us, particularly hospital systems, is this phenomenon of staggering peaks. RSV has been peaking before flu and then before COVID. We think this pattern is absolutely fascinating because this hasn't really been studied before. But the running hypothesis is there's these cross protection pushing these peaks. So say someone gets infected with RSV, they stay home, delay getting infected with flu, and that pushes that peak further, which then pushes COVID over further. And I think it'll be really interesting to see if this pattern persists over time. So I'm a little over time, but in summary, I want you guys to take away that the majority of us epidemiologists think we're in this new normal. This new normal doesn't mean that there's no suffering or no stress on our healthcare systems with this new repertoire of threat. And most importantly, I think we need to remain humble, not only on what is to come, but to increase trust and vaccine uptake, something that everyone needs to be incredibly hyper-focused on these days, and for a very good reason. So I will stop sharing and hand this over to you, Dan.
Thanks so much. Let me go ahead and share my screen. All right. Does that look okay? All right, thanks. So I'm excited to be speaking at Grand Rounds. As Dr. Law mentioned, I've been in this audience since I was a medical student, so it's really an honor. And thanks to Dr. Jolina for reviewing the epidemiology. And so now we'll discuss vaccines for prevention. I have no relevant financial disclosures. I have been a co-investigator on some COVID vaccine trials at the Hope Clinic, which is the clinical trial arm of the Emory Vaccine Center. And one thing I want to say to the students, residents, and fellows in the audience is that the connections you make through your clinical work can really have a huge impact on your career. So my opportunities to do research, both in residency and fellowship, came from working with mentors clinically on clinical services and really led to my involvement in clinical trials and my current work. So just keep your eyes and ears open for people who are doing things you're interested in, and see where that might lead you. So to start, I'd like to reemphasize the success of vaccines against COVID, both in terms of the speed of development, less than a year from availability of the sequence to vaccine availability. It's compared to over 10 years for most vaccines, so this is really phenomenal. And this led to the largest immunization campaign in history, over 13 billion doses administered globally. It's estimated that the US averted over 3 million deaths, close to 20 million hospitalizations through 2022. Globally, the estimate's somewhere from 14 to 20 million deaths averted. So really impactful vaccine development and implementation. As Caitlin mentioned, we really had great primary series coverage from that first vaccine, and over 95% among those most at risk in the over 65 age group. And this really set the stage for where we are with COVID and vaccines at this point. So a little bit more on Epi very briefly, just that we're in a very different situation from 2021-22. The major change being that we do have protection against severe disease and death provided by immunity, particularly hybrid immunity, which is from a combination of infection and vaccination. So it's estimated that most of the population had some degree of immunity by late 2022, now estimated over 98% of the population. So most of us have been exposed, vaccinated, or infected, or probably a combination. And so while COVID ED visits, admissions, and deaths do still occur, and there's still work to do, the increases or the peaks in cases and test positivity no longer consistently predict a substantial increase in deaths. The key, though, is that of people who are still getting severely ill, for example, people hospitalized last fall, over 95% of adults who were hospitalized with COVID were not up to date with their vaccines. So the uptake issue is a real one. So it's in the context of most of the population having some immunity that we have to interpret the effectiveness of our current vaccines. The 2023-24 vaccine targeted the XBB lineage, which was circulating at the time, and was fairly effective against hospitalization due to that lineage, up to about 54% estimate on the top row. But this effectiveness decreased substantially against the JN lineage later. You can see in these lower rows, and waned with time as you get further out from your dose. And in this study, JN1 was really the dominant lineage among the cases by mid-January. So the available vaccines at the time were providing less protection as the respiratory season went on. Looked at it from other studies, vaccine effectiveness from 2023-24, this was compared to no updated vaccination in that season. So in these top rows among adults and adolescents, the pooled effectiveness was estimated to be around 40% for medically attended COVID or hospitalization. And in a separate study among adults during the respiratory season, so September to May, estimated around 49% effectiveness against hospitalization, a little higher against critical illness, nearly 70%. But by 4 months, that protection against hospitalization had waned, and a little bit, but maybe more durable against critical illness. And then in the lower rows against symptomatic infection, which is not the primary goal of these vaccines, but did provide some protection, but again, lower during the JN1 period. So as we've discussed, we know protection from vaccines wanes, and it does depend on which outcome you're looking at. But in the meantime, variants continue to develop, and that has spurred the changes in these updated vaccines. So to talk about the current vaccines for 2024-25, these are targeting the recently circulating variants. These are monovalent vaccines based on the Omicron JN1 lineage. So there are two platforms available, the mRNA that we're all familiar with, and that encodes the spike protein from the KP2 strain. And the second is an adjuvanted protein subunit vaccine with the spike protein with the JN1 strain. So while they have different names, they're both part of the JN1 lineage, they're closely related. And both these vaccines have been authorized by FDA. That was done in August. So full approval for the mRNA platform for those ages 12 and up, and emergency use authorization still for younger kids. And then emergency use authorization for the protein subunit vaccine for those 12 and up. This is from Novavax, and I think it's important because it provides an option that's not mRNA for those who may prefer not to take mRNA vaccine for whatever reason, or they may have an allergy to components of the mRNA vaccine. So that gives us another option for people to receive vaccine and hopefully improve that vaccination coverage. And the expectation is that the targeting the JN1 with the antigen will be protective against current variants based on the evidence we've seen from prior vaccines. So just to briefly state what the ACIP recommends is that everyone 6 months and older get a vaccine. For those 5 and up, that's a single dose of the updated vaccine. And for younger kids, it's a multi-dose series, a few doses depending on which mRNA product they'd be receiving. And to note that immunocompromised patients should receive at least 1 dose of the current vaccine or multiple doses if this is their initial series. Dr. Generalina covered this very well in terms of vaccine uptake. I think this is really important because despite recommendations for everyone to get a dose last year, there was pretty low uptake of the 2023-24 vaccine, just about 20% among all adults, less than 40% among those 65 and up. And this kind of data was already covered in terms of intention to get vaccinated, still less than 30% for the updated vaccine, and in comparison for flu, usually consistently over 40%. So this is a challenge with these vaccines, and I do think that if we can better understand the immune response to the existing vaccines and inform development of future vaccines, give us more options and also potentially vaccines that people might have more confidence in. So one such effort to really get a better grasp of the immunology was this multi-site COVAIL trial, which was an NIH-funded study that Emory participated in. This is an open-label randomized study of healthy adults who had received a single booster dose and were at least 16 weeks from their last antigen exposure, so that's for last vaccine or infection. And it enrolled in multiple sites, including here. There was a lot of data collected, but what I'll focus on is neutralizing antibodies. So those titers were collected at baseline and at day 15, so 2 weeks after vaccination, and then additional time points out to basically day 180. So these data are from the stage 3 of the COVAIL, which was enrolled in June 2022. And these participants received an adjuvanted protein recombinant vaccine from Sanofi. This panel illustrates that neutralizing antibodies, again at day 15, has a correlate of risk for incident COVID. So can this give us information about whether someone will get COVID or not, following them out for 22 to 200 days from vaccination. So these figures show the distribution of neutralizing antibody titers at day 15 for cases, which are in blue, and non-cases in orange. And each individual panel is different variants, and then on the far right is a weighted average. So you can see that there's pretty consistently lower neutralizing antibody titers among cases of COVID in this study. So looking at antibodies as a correlate in a different way, this figure shows the cumulative incidence of COVID as it changes with what that neutralizing antibody was at day 15. And this example is against BA.4/5. So there's a few different lines here on the figure. The Cox model is the red smoother line, a non-parametric model more stepwise in blue, but you can see they follow a similar trajectory. And then the green shaded region is an estimate of the day 15 neutralizing antibody titer. And what this shows is that as neutralizing antibody at day 15 increases along the x-axis, the adjusted risk of COVID decreases. And so looked at a different way in the table on the right, showing the probability of acquiring BA.4/5 infection by the neutralizing antibody value. So for an undetectable titer, the probability of infection was about 40 to 50%. And as that titer increased, so up to 1,000, the probability was decreased to 15%. And then with even higher titers down to 7%. So this is consistent with results from other vaccine platforms in this study, including the currently available, or including the mRNA and protein subunit vaccine platforms. And some data I didn't show here was that the neutralizing antibody titers were fairly stable over time, but actually performed better as a correlate of risk out to 3 months. So this fits with what we know about waning protection, but there's something other than just antibodies that explains that waning. So cellular immunity is important and does provide more durable protection, but we're going to need to develop better vaccines going forward. to hopefully provide longer protection for us against COVID. So to that point, the vaccines we have are good at preventing severe outcomes, but can we do better to prevent infection, transmission, to protect individuals who receive the vaccine, but also as was discussed, to better protect others in the community who may not be able to be vaccinated. So Project NextGen is a government-wide project that is with the goal of developing tools for COVID preparedness. This is led by BARDA and NIAID, and has multiple goals, but those on the vaccine front includes improving the durability of immunity, how long the vaccines provide protection, protecting against future variants and other viruses of pandemic potential, and to develop other strategies such as mucosal vaccines with the goal of decreasing transmission. And they're doing this with a pipeline of next generation vaccine studies, including early phase trials using centralized assays. We were involved at the Hope Clinic in an effort for assay development through a kind of sequential mucosal sampling study. And now the Emory VTU and Hope Clinic are part of this study, which is the first NIAID trial out of the NextGen project. So this is a phase 1 trial that we're enrolling currently, using a intranasal vaccine in a dose escalation study. This is using a murine or mouse pneumonia virus vector, which encodes the spike protein. And this candidate in non-human primate studies generated a good immune response systemically and mucosal immunity, and protected non-human primates from SARS-CoV-2 challenge. So a promising candidate. The participants will have received at least 3 doses of mRNA previously. Since it's a phase 1 study, the main objectives are safety and reactogenicity from the vaccine, but we'll also be looking at systemic and mucosal immune response, so IgA and IgG, and evaluating the vector and the immune response to the vector itself. This is important because secretory IgA has been shown to be a correlate of protection against SARS-CoV-2. So this study will both evaluate a potential next-gen vaccine candidate, but also we hope improve our understanding of mucosal immunity against SARS-CoV-2. So I know I've recycled these wild to mild figures, but I really like the message that our vaccines, both for COVID and flu, protect against severe disease and hospitalization. They may not prevent all infections, but if you do get infected, your illness is likely to be milder than it would be if you were unvaccinated. And so this is also a reminder to get your flu vaccine, which I know most of you are required to do, but also to talk to your patients about getting their flu vaccine. We know that it is safe and effective to get both COVID and flu vaccines at the same time. Vaccine safety is really essential, and it supports effective communication with patients about vaccination. So just wanted to highlight the CDC's clinical immunization safety assessment. Emory and Children's is a site. Satoshi Kamadani at the Emory Children's Center is the PI. And if you have a clinical question about vaccine safety for an individual patient, there's actually a consultation service that you can request, and they'll be happy to help you sort out vaccination for your patients. So I'd like to thank Nadine Rufel, who's the director of the Hope Clinic, but really the entire Hope Clinic team for the work that they do, and to encourage you to consider volunteering for one of our studies, talk to your patients about our studies, COVID or otherwise. We have some that are just a blood draw or some nasal swabs. And particularly if you plan to get the Novavax vaccine, please let us know. Thanks for your attention and for discussing vaccines with your patients. I'll go ahead and stop sharing and hand it over to Dr. Chu.
Okay, great. Thank you so much. I'm really excited to be here today, and thanks to Dr. Del Rio and Armstrong for the invitation, and Dr. Law for the introduction. These are my disclosures. I am a current IDSA COVID-19 treatment guidelines panel member and have some relationships with Pfizer and Shionogi, but not any direct funding. But the views I present today are my own, so just remember that. And just in terms of sharing something personal, I think the theme for that, for me, especially related to COVID, is to embrace the unexpected. So for the trainees in the room, COVID didn't exist when I was a trainee or in my early faculty career, and then it came along, and I was already I was an HIV researcher and heavily involved in clinical trials with the ACTG Clinical Trials Network, and there was a COVID trial that was just starting to be talked about. And I really wasn't sure how involved I wanted to be with COVID, but thought, well, this is interesting, and I think I'd like to do something. And so just sort of casually said, I can help if needed, having no idea that that would eventually lead to leadership roles in various COVID treatment trials that are ongoing today. And so I would just say for the trainees in the room, be open to opportunities that arise, embrace the unexpected, including, what those opportunities might offer you ultimately may be unknown, and it may be the best surprise, and regardless, you'll learn a lot. Okay, so learning objective today is to review current treatment options for acute COVID-19 in non-hospitalized adults. Here's a case for context. This is a 52-year-old woman you're seeing through a telehealth visit. She has hypertension on 2 agents, BMI of 30, and she has received a number of COVID vaccines, but not the last 2 boosters. Has 1 prior SARS-CoV-2 infection of which she is aware about a year ago. And she's on day 2 of acute COVID-19 with some symptoms, not feeling great, but not having any particularly concerning symptoms for lower respiratory tract disease. So just think about this, like, would you recommend an antiviral for this individual? So let's look at the data. And when we think about goals of treatment of acute COVID-19, I think there are really 3 main goals that are important to people. The primary one is prevention of progression of disease to severe disease and hospitalization or death. And then as hospitalization rates have come down, I think there's a lot of interest, of course, in reducing symptoms or accelerating symptom recovery, getting back out there in the world. And then a lot of interest in whether or not acute treatment can prevent long COVID. And so since I do clinical trials, I think about this a lot in terms of what we measure in clinical trials and then how we can translate that to how we actually recommend treatment for individuals. So it's easy with hospitalizations and deaths, and that's pretty consistent across trials, looking at 28-day composite of COVID-related hospitalization or death. But for reducing symptoms, these outcomes are really variable across studies, generally using time to sustained symptom improvement or symptom resolution, but different across studies and using patient-reported outcomes. So diaries that they fill out daily for 4 weeks. So you can imagine how challenging that can be. And then for long COVID, there are no RCTs yet, where this is the primary outcome, looking at an acute intervention. And again, long COVID definitions are very variable. So what are our current treatment options for non-hospitalized adults? So there are 3, and these are the ones that are FDA approved or authorized for treatment of high-risk persons to prevent progression to hospitalization or death. So no indication for symptom reduction, no indication for long COVID prevention. And the main recommended ones are ritonavir-boosted nirmatrelvir and remdesivir. These had high efficacy in preventing hospitalization or death in the pre-Omicron, pre-widespread vaccination era in RCTs. Major limitations do exist for these, primarily drug interactions for nirmatrelvir. Also, you can't use it in advanced kidney or liver disease. And for remdesivir, it's intravenous for 3 days. But both are highly efficacious, at least based on original RCT data, and both can be used in pregnancy. And the alternative is molnupiravir. This is not FDA approved. It still has an EUA. The efficacy was observed to be lower in the primary RCT that examined this. And there's also concern for mutagenicity based on its mechanism of action. And so it's not recommended for use in pregnancy. So we know that these drugs were effective in a previous era. So what are the benefits today in the Omicron era and vaccinated persons? I would say we still don't have like a lot of data in the very current contemporary period, but we do have data in the Omicron period. And this was one CDC analysis looking at about 700,000 people who were all eligible for nirmatrelvir. And majority were had received multiple mRNA vaccine doses. And one thing I want to point out first is for all of these people that are eligible, there was a very low prescription rate. So only 28% were prescribed nirmatrelvir, though they were eligible, and uptake has not improved. And so I think upcoming at this big ID meeting this week, there's going to be some data presented of a recent survey in adults at high risk, and only 16.5% had said that they had received COVID treatment, and only 23% said they would take an antiviral if prescribed. So that's interesting. And in the CDC analysis, also of interest was that those who are most socially vulnerable were the least likely to be prescribed nirmatrelvir. So I want everyone to keep that in mind, that this really highlights some inequities that we're all well aware of in terms of access to treatment. So then getting into how well nirmatrelvir actually reduces severe outcomes. So here looking at 3 different age categories. With increasing age, there were, as expected, increasing event rates. But there was benefit observed in reducing hospitalization within 30 days across all age groups. In the younger age groups, so 18 to 49 and 50 to 64, the benefit was really most observed in people who had underlying conditions, and in the youngest age group, those who had at least 2 or more underlying conditions. But there was still benefit observed, and benefit observed even in people who were vaccinated and older. Here's another analysis that got into a little bit of the XBB period of Omicron. This looked at nirmatrelvir and death from any cause or COVID-related emergency hospital visit or admission using British Columbia Ministry of Health data. A retrospective analysis, this is what we're left with contemporary populations. What they saw looking at mutually exclusive groups of different degrees of risk for severe disease, including different degrees of being immunocompromised, other particular high-risk conditions, and then this group that they called Excel, which was this expanded eligibility group, generally defined as being under-vaccinated or unvaccinated, and of older age, 50 or 70 plus, or having at least 3 chronic conditions of the types we typically would consider as being potential risk factors for severe disease. And so across these groups, the benefit was most observed in the immunocompromised groups and those with particular high-risk conditions, but not observed in that expanded eligibility group that was at relative lower risk. In this other analysis, another retrospective analysis, in the Cleveland Clinic COVID registry, they looked at the effect of nirmatrelvir or molnupiravir on risk of death through 90 days. Here are cumulative incidence curves for that outcome. And what you can see is that with both nirmatrelvir and molnupiravir, there was a big reduction in risk of death through 90 days. In an adjusted analysis, this panned out because there were some differences between the treated and untreated groups that were important. And benefits were observed across various subgroups, including older and younger age. And then for remdesivir, there's not that much data. This is the only study I'm aware of remdesivir in outpatients. But overall, the data also continue to support remdesivir in terms of reducing serious complications like all-cause hospitalization in those who are not hospitalized or who are hospitalized and not requiring oxygen. In this case, the treatment effect was greater in the older group and less in the younger group under 65, but there were still benefits across vaccination status and Omicron subvariant period. Okay, so we see now that, and we all know that risk of severe disease is greatest in immunocompromised patients, and that risk persists now, of course. And so how do we manage this group of patients in particular? So I think the first line is still either single agent nirmatrelvir or remdesivir if they can be given, with molnupiravir as an alternative if they can't. And one of the biggest issues are the drug-drug interactions with nirmatrelvir for patients who are transplant recipients. There are some centers that have developed protocols to manage these drug interactions. The other thing that comes to mind sometimes for people is whether or not to use combination therapy. And I think this makes, there's good reasoning for this in terms of either more than one antiviral or of more interest maybe considering the immunodeficiencies in this population, combining an antiviral with an antibody-based therapy. But there are no clinical trial data on using combination therapy up front, and so or later, and so I think first up is still single agent therapy. There are not many options for antibody-based therapy now. We don't have any active mAbs, monoclonal antibodies for COVID treatment, and none authorized. There is still an EUA for COVID-19 convalescent plasma, and kind of limitations to that are this plasma needs to be high titer in terms of in vitro neutralization, and it's really challenging to access CCP that has been recently collected so that you know that there's going to be good activity against whatever variant is circulating. And there are also uncertainties as to how to dose it and how frequently to give it. And then another consideration, particularly in the immunocompromised population, is resistance. So this has been well described now for various antivirals for COVID-19 in the immunocompromised population. It's still uncommon, and it is more likely in this population because they have persistent infection and are more likely to be exposed to prolonged or repeated treatment courses, which offers more opportunity for selection of resistance. And in this paper that was recently published, not that long ago, this group, Tumor et al., looked at nirmatrelvir and remdesivir resistance during and after treatment. And there was a higher frequency of nirmatrelvir resistance detected in the immunosuppressed population compared to those who were untreated, numerically more than in those who were not immunosuppressed. And you can see that the sample sizes are fairly small, but there was no association with viral rebound. Overall, the resistance that was detected was of low frequency, less than 20% of the viral population, and transient. And so the clinical significance is unclear. And right now, clinically significant resistance is infrequent or uncertain. But something to keep in mind. So again, would avoid prolonged or repeated treatment courses unless really, there's good reason. And in fact, there was an RCT called EPIC-IC that looked at whether or not there was any benefit of extended duration nirmatrelvir for acute COVID-19 treatment in immunocompromised persons. So this was a double-blind RCT that compared 5 versus 10 versus 15 days of ritonavir boosted nirmatrelvir. Included people 12 years of age and older. 38% were considered to be severely immunocompromised, based on like CAR T or B-cell depleting therapies. And their primary outcome was the proportion with nasopharyngeal SARS-CoV-2 RNA viral RNA levels below the limit of quantification in the post-treatment period, so days 15 to 44. And here's that figure for the primary outcome. And what you can see is that between the three arms, 5, 10, and 15 days, these bars don't look very different. Not a lot of difference in the proportion with viral RNA suppression in this in that post-treatment period. So about 60 to 70%. And then if you look at individual participant level viral RNA levels, so each of these lines longitudinally represents one participant, where they've highlighted the severely immunocompromised in orange. With the 5-day course, it does look like there's a little bit more of higher viral RNA levels in the post-treatment period, not seen with 10 or 15 days, and 10 and 15 days look quite similar. So maybe there's some potential benefit within the very severely immunocompromised group in terms of viral clearance or viral suppression with extending the course a bit. But the clinical relevance of this is really uncertain, and I think we'll look to the manuscript when it's out to really dig into the details. But right now, for most people, it doesn't appear that there's necessarily a benefit with extending the course up front. Okay, so we've talked about hospitalizations and deaths, and then everyone, I think wants also their symptoms to get better faster, but we don't have a lot of great RCT data for this, and the data that we have are not very compelling. So for nirmatrelvir, there was EPIC-SR. This was a study conducted into early Omicron, a double-blind RCT of nirmatrelvir versus placebo, and people who were vaccinated and had at least one risk factor for severe disease or no risk factors and were unvaccinated or hadn't received a vaccine in the previous year. The primary outcome, and this is like one of the few RCTs with symptom outcome as primary, and the primary outcome was time to sustain, and in this case, 4 days alleviation of 11 targeted symptoms through day 28. And the median symptom duration then, or time to sustain alleviation, was 12 days in the nirmatrelvir group, 13 in the placebo group, not different. And so that's kind of what we have for RCT data from nirmatrelvir. And then for molnupiravir, there's panoramic. And in this case, this was an open label RCT of molnupiravir plus usual care versus usual care alone in a vaccinated population. They reported a secondary outcome of 4 days benefit in time to first instance. The participant reported feeling fully recovered. So you can see already there's some limitations to that outcome. They did look at others requiring some more sustained benefit. But I think the primary issue here is that this was an open label RCT. The participants knew what they were getting. And so that's a real challenge in terms of potential bias for an outcome that is a participant reported outcome. Okay, and then finally, can acute treatment prevent long COVID? Lots of interest here. And biggest issue is, well, we don't have any RCTs for this as far as the available therapies. And long COVID definitions have been highly variable across studies. There's been limited population diversity in terms of the analyses, and a lot of potential because a lot of these analyses are retrospective or, in the molnupiravir case, open label again. And there's a lot of potential for bias or unaddressed confounders in these study designs. And so ultimately, the findings are mixed on potential benefit. Most of the studies have been in high-risk persons because that's who was eligible for these therapies. So far, it seems the most of any potential benefit is in these high-risk persons. There's a preprint out of a recover analysis where there was not a benefit seen in lower risk persons. And while some report benefit on certain measures, overall, the absolute risk differences are quite small. And just to illustrate on the left, there are 2 studies, both looking at acute nirmatrelvir treatment and different long COVID type outcomes, both using VA databases with different findings. So in the first analysis, they saw benefit. In the second analysis, they saw no benefit looking at 31 possible post-COVID conditions, except for in just combined VTE or PE. And then for molnupiravir, this just came out not too long ago. They looked at 3 and 6 month long-term outcomes in panoramic, saw some benefit, but again, altogether, small absolute risk differences. And so I think it's really uncertain still, what the benefit is of acute treatment on long COVID. Okay. So finally, just summarizing treatment decisions for non-hospitalized adults. Use nirmatrelvir ritonavir in the highest risk for progression. I would consider that to be immunocompromised or older, 65 plus, especially with comorbidities or under-vaccinated. Use remdesivir in that population if you can't take nirmatrelvir, and we're probably limited logistically to that population anyway. Use molnupiravir only if the others are not an option and someone's at high risk for progression. And for other outcomes and for lesser risk people, use shared decision making. There's a lot of concern about rebound for nirmatrelvir. It has not been, viral rebound at least, linked to worse clinical outcomes. And so definitely still treat if indicated for those people that are at risk for hospitalization or death. And so getting back to our case, this 52-year-old woman, she has a couple risk factors for progression. Overall, her hospitalization risk, absolute risk, is probably quite low, but there may be some benefit. And so I think that's a shared decision-making setting. All right, I think that's all I have. Thank you.
Excellent. Thank you so much, Dr. Chu, Dr. Gracia, and Dr. Ditalina for this wonderful overview. And we have just a little bit of time for questions, and so I want to see if we can get to them all. I will say that in the chat and on my texts, some of the biggest questions are really around vaccine recommendations. So maybe we'll start with Carlos's point, and I'd love to have the panel's input on this. Carlos Del Rio said, I must say I'm not a huge fan of vaccinating healthy young men who have previously been vaccinated and have had COVID. I feel that targeting high-risk populations such as greater than 65 and immunocompromised makes more sense. And it sounds like that is what the Europeans are doing, and there are some SAGE recommendations that have been dropped into the chat. Help us make sense of this. How do we, what is the panel's recommendations on how we counsel our patients and how we prioritize our vaccine messaging?
I mean, I agree that the priority should be on those who are at highest risk for severe outcomes, certainly on a population level. But I think from a vaccine messaging standpoint, I think it's important to say that there is potential benefit from getting updated vaccines for a broader proportion of the population. I think that the safety question, I think Carlos was getting at myocarditis in otherwise healthy young men. If they've gotten a previous dose of the the vaccine and they're otherwise healthy, I agree it could be a, kind of personal decision or risk-benefit discussion. But I think that the focus should be on those who are at higher risk, whether it's because of their age category or comorbid conditions that they have. And I think that the recommendation are broad, probably to make it more manageable for busy clinicians who are in clinic with patients to make that recommendation to say, we're recommending everyone get an updated vaccine. But yeah, I'm happy to hear what others have to think.
Caitlin, would love your input.
Yeah, I think I think about it a little differently than physicians maybe because as an epidemiologist, we try to treat millions at a time, populations at a time instead of one-on-one. What we found during the flu vaccine about a decade ago is the broader the recommendation, the actual more high-risk people get that vaccine because it increases access, it increases convenience. And so there's like a behavioral thing behind policy recommendations, at least in the United States, that has very little safety nets in place, specifically for government, for example, paying for vaccines for children. And so I think from a population level perspective, yes. As a mom of two little girls, I'm not running out and getting the vaccines like I did the primary series. I think about it like the flu shot, honestly, that it will help with some of the disruption in my life. Not entirely concerned about them heading into the hospital though, because they are healthy. And so I think we can hold both of those kind of competing truths at the same time.
Very helpful. And one follow-up question on that, and then we'll pick up with Bob Taylor's question. As we think about counseling our patients and having these nuanced shared decision-making conversations, what recommendations does this group have, for example, for that young, healthy male group where we have a worry about myocarditis? How do we have that conversation? I've tried to have it, and my patients say, well, I don't want myocarditis, so I'm good. And it feels like it just closes the door to me having additional conversations with them about the public health perspective, about the fact that they've gotten COVID or the COVID vaccine before and have been able to recover. Any recommendations from the group?
I tell them to go get their HPV vaccine. That's the one they really need.
Other comments,
But I
Kara?
wonder, I mean, I don't know, Dan, if you have an opinion. I think, the myocarditis risk has been observed more with the mRNA vaccines. There is the Novavax option if they have significant, concern and desire to get vaccinated. Like Dan, what do you think?
Yeah, that's what I was going to say. I completely agree. I mean, I think the I would say on a population level, like the safety has been borne out by the data. Like while there was a risk of myocarditis, there was also a risk of myocarditis from having COVID infection. And then now we do have an alternative. So if people are very focused, if a patient's very focused on mRNA and not wanting to get that, we have another option to present to them. And I agree with others have said that, from a population standpoint, public health standpoint, it's important to recommend vaccination because of the other benefits, not just to the patient in front of you, but to the people they live with, the people they work with. And I think that's really a key about developing new, better vaccines that will better interrupt transmission, because these vaccines, while they do have that benefit, that's not what they were meant to do. And so that's, not their strength. But I still think the recommendation for everyone is important.
That's great. And so then just to round out this discussion right at 1 o'clock, we were just talking about our healthier individuals. What about our high-risk individuals? So Bob Taylor's question is really, as we know that vaccine efficacy decreases over time and we're anticipating a January peak, what do we counsel our elderly patients who are super eager about either getting the vaccine or they got it as soon as it came out in September? How do we help them to manage the January peak? And do we have any additional recommendations for vaccines for them?
I think it's kind of interesting, right? Because I think that this year the CDC is no longer necessarily recommending twice a year doses for older people who are not otherwise more immunocompromised.
Yeah, I agree. I think one key thing about timing, and like you said, some people are very enthusiastic, they run out and get it as soon as it's available, is that, if you did get a vaccine or or infection that you have a boost for several months. I think, trying to time it in the winter would be tough. And also that recommendation is not necessarily there for people to get updated vaccines. But I think the key is that if they did get the updated vaccine, that they are protected against severe disease and hospitalization from the more recently circulating variants.
So maybe the recommendation is definitely try to get it. If you can, try to optimally time it and you haven't gotten it yet, maybe wait. But if you've already gotten it, at least you got it and you're protected against the most severe variants.
Severe disease.
Severe disease. Severe
Yeah.
disease. Thank you, Kara. Yes. All right. Thank you all so much for this fantastic update. If we have other questions in the chat, I'll go through them. Then if we haven't addressed them, I'll make sure that we get answers to everyone. Thank you, Dr. Jolina, Dr. Chu, Dr. Grasha, for an awesome update.
Thank you so much.
Thank you.
Have a great ID week, guys.
Thanks.